Temperature 105.8, heart rate 148, and it just went into atrial fibrillation. Your patient is agitated, confused, burning up, and she has a history of hyperthyroidism. This is a thyroid storm, a body redlining. You have a stack of orders in front of you. Which one do you give first? Here is your question. A client in thyroid storm has a temperature of 105.8, a heart rate of 148 with new atrial fibrillation and severe agitation. The provider orders propranolol, PTU, iodine, and hydrocortisone. Which action is the priority? A. Give propranolol to control the heart rate and the adrenergic surge. B. Give the iodine now to stop hormone release. C. Give aspirin to bring the fever down. D. Place a cooling blanket and continue to monitor. Pause right now and commit. 3, 2, 1. The answer is A. Propranolol. In a thyroid storm, the immediate killer is the cardiovascular surge, the racing, irregular heart driven by a flood of thyroid hormone. The beta blocker is what pulls that back, fastest. It calms the heart, blunts the tremor and the agitation, and even slows the conversion of thyroid hormone to its active form. You control the storm's engine first. Here is why. Too much thyroid hormone turns the whole metabolism up, and it makes the body exquisitely sensitive to adrenaline. Add a trigger, an infection, a surgery, an iodine load, and it tips into a storm. The temperature climbs, the heart races and fibrillates, the patient becomes delirious. You are here. If you do not break the cycle, the heart fails from the strain, and the storm turns fatal. It helps to see it against its opposite. Myxedema coma is too little thyroid hormone. The patient is cold, their heart is slow, they are lethargic and sliding toward coma, and the fix is to give thyroid hormone and rewarm them, slowly. Thyroid storm is the mirror image. Too much. Burning up, heart racing, agitated and delirious, and the job is to block the hormone and cool them down. One body running too cold, the other too hot. So here is the order of operations, and the order matters. First, beta block, propranolol, to control the heart and the surge. Second, block synthesis. PTU, to stop the thyroid from making new hormone. Third, block release. Iodine, but only after the PTU, at least an hour later, along with steroids. Beta block, then block the factory, then lock the warehouse. Here is the rule to carry out of this. In a thyroid storm, beta block first for the surge. Give the PTU before the iodine, always. And cool the fever with acetaminophen, never aspirin. So how do you know it is a storm, and not just hyperthyroidism? It is the severity, and the tipping point, a high fever, often over 104, a racing heart, often in atrial fibrillation, agitation or delirium, vomiting and diarrhea, signs the heart is failing. And a trigger in the story, an infection, a recent surgery, an iodine load. And here is the key. It is a clinical diagnosis. You do not wait for the thyroid levels to come back. You treat. 2 drugs, 2 different jobs, and you need both. The propranolol works fast. It calms the heart and the surge within minutes, but it does nothing to the thyroid itself. The PTU works on the source. It shuts down the production of new hormone, but it is slow, and it cannot rescue the racing heart on its own. So the beta blocker buys you time, and the PTU fixes the cause. One without the other is half a treatment. Now 2 drugs that will backfire, because both are tempting. First, aspirin. The fever is 105, and aspirin is the reflex, but aspirin pushes thyroid hormone off its carrier proteins and raises the free level, feeding the storm. Cool with acetaminophen instead. Second, iodine, given too early. Iodine belongs in the treatment, but if it goes in before the PTU, it hands the thyroid the raw material to make even more hormone. Order matters. PTU first. 2 to lock in. For the sequence, block, 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 beta block first. then block synthesis with PTU, then block release with iodine after the PTU, and steroids block conversion. For support, cool, but not with aspirin. Acetaminophen, fluids, and find the trigger. Beta block PTU, then iodine. Never iodine first. Now the wrong answers. B. Give the iodine now. Iodine is real thyroid storm treatment, but before the PTU it feeds new hormone synthesis. Right drug, dangerously wrong order. That is the trap. C. Aspirin for the fever. It seems obvious, but it raises the free thyroid hormone level and makes the storm worse. Reach for acetaminophen. And D. A cooling blanket and monitor. Cooling helps, but on its own it ignores the racing, fibrillating heart, and that heart is the immediate threat. Beta block it. Tie it together. Your cues: a temperature of 105.8, a heart rate of 148 in new atrial fibrillation, agitation, and a hyperthyroid history with a trigger. Your action: propranolol first, then PTU, then iodine, with steroids, acetaminophen, cooling, and treatment of the trigger. And the outcomes you are steering toward: the heart rate controlled, new hormone shut off, the fever coming down, and the storm reversed. Now test yourself. Different thyroid patient, also altered, but this one is cold. Her temperature is 34.5, her heart rate is 44, and she is barely rousable. Same treatment? No. This is the opposite emergency. Myxedema coma, severe hypothyroidism, cold, slow, sliding toward coma. The fix is the mirror image too. Give thyroid hormone, add steroids, and rewarm her slowly. Everything you block in a storm you replace here, the direction flipped. One more. A classic storm in front of you, but the thyroid labs will not be back for hours, and the team wants to wait for them to confirm it. Do you hold treatment? No. Treat now. Thyroid storm is a clinical diagnosis, and it kills faster than the lab returns. If the picture fits, a hyperthyroid history, a fever, a racing heart, and an altered mind, you treat empirically. The labs confirm the diagnosis. They do not gate the treatment. One last look. The storm is settling with treatment, but should you stop there? No. A storm almost always has a spark. Infection is the classic one, but also surgery, trauma, an iodine load, or stopping antithyroid medication. This patient has a new cough, a fever, and a high white count. It is a pneumonia. Miss the trigger, and the storm reignites. You treat the cause, not just the thyroid. Next episode. A patient in the recovery room after surgery. The temperature is climbing fast, the jaw is clenched rigid, and the carbon dioxide on the monitor is shooting up. This is malignant hyperthermia, and there is an antidote you have only minutes to give. What is it? That is episode 7.